This brief lecture is about the language of the skin exam. We'll look at terminology of dermatology and how that relates to accurate diagnosis of skin lesions and rashes. The objectives of this brief lecture are to define and describe the terminology of skin lesions. We're going to look specifically at the type of lesion, color, margins, shape and size, consistency, which is evaluated through palpation, arrangement, and distribution. We'll also analyze a dermatology case study I saw this week, polymorphic eruption of pregnancy. It isn't the intent to diagnose the case because I gave you the diagnosis, but it's to describe it and to document the skin lesion in the case study. The common language used to describe a skin lesion is called morphology. I think that people get confused because one of the most important things is to know the difference between primary lesions and secondary lesions. And I'm not sure that most nurses would think that the terminology used to describe primary lesions and all secondary lesions are common. Some are, but often they're not. So let's talk about primary and secondary lesions. And for you that know, this will be just a review, but often I find that nurses are not clear on the difference. Primary lesions, they arise from normal skin. They're an anatomic change in the epidermis, the dermis, or the subcutaneous tissue. I gave you examples, descriptions, and the name of the lesion. So a macule, for instance, is less than 1 centimeter. It's completely flat. Nothing's raised on it. And a freckle is an example. Look at the patch. It's greater than 1 centimeter flat. And an example is vitiligo. I'll visually example that in a moment. A wheal, also urticaria. It's superficial, edematous, and an example is hives. So you can read these other primary lesions, but know that their descriptors are what lead you to being able to name that type of lesion or rash. Once you think about your primary lesion, you really are thinking in terms of the type of lesion and what it's based on. For instance, again, those descriptors, the diameter of the lesion, the size. Is it less than or greater than? The relationship of the lesion to the surface of the skin. Is it flat or is it raised? And then the composition of the lesion, that's so important. Is it solid? Is it fluid-filled? Is it pus-filled? These all lead us to our diagnoses of those primary lesions. A secondary lesion results from changes in a primary lesion. That's it. Now, this is not an exhaustive list. Scale, crust, lichenification, excoriation, fissure, ulcer, scar. But if you have a primary lesion and there are changes, then it creates a secondary lesion. And believe it or not, we often have 2 or 3 different types of descriptors going on and lesions going on. And what I mean by that, in today's case study, you'll see that we have a macular-papular rash. So there's some flat that fit that description, and then there's some raised lesions that you can palpate and feel and see that they're raised. So here's a brief look at that patch I talked about in the earlier slide, the primary lesion. This is vitiligo. The patch happens to be related to melanocytes that have had an immune deficiency and are no longer responding to create color within the skin. You can imagine the profound effect that this would have on a person. The secondary lesion you're visualizing actually started from vesicles and bullae, because you know that a vesicle is a small blister and a bullae is a descriptor that's over a certain size, but they've now dried and there are scales that have formed over those vesicles and bullae. So now it's important for us to think about the color of a lesion. Now, you might be very familiar with the terms hyperpigmented and hypopigmented, and that's often used in really comparison to the patient's overall skin color. It's either lighter than or darker than. And we're all familiar as nurses with erythema and erythematous terms, which really talk about red hues from pink to just really bright red, and that usually are associated with dilated blood vessels in the dermis. But there's many other colors we use as descriptors, and that leads us to an accurate diagnosis. So just take a moment to look at the examples of color and the causes or the possible causes of color change, and the example of lesions or diagnoses that can be made. So the next descriptor we're going to talk about is size and margins. So most sources use a lesion diameter of either a half or 1 centimeter, less than or greater than, to distinguish between different lesion types. But you can really use any unit of measurement if it's appropriate. Okay, so today's example, I think I use millimeters because it's more appropriate. And when you're talking about the margins of a lesion, they're either well-defined, nice and sharp and discrete, or they're ill-defined. They're foggy and they're blurry, and you can't really put a nice, clear, sharp definition to the border. So when we talk about palpation of the lesion, you've got to consider, or consistency of the lesion, that's discovered through palpation. And there's instances when we don't palpate an open, oozing wound, but often on lesions we have the opportunity and should take it. Would we say the consistency is soft, firm, hard, fluctuant, or board-like? Those are also cues to diagnoses. Is there a deviation in temperature? Is it hot, cold? Is it normal body temperature? Is it mobile? Can you move the lesion or the mass? So those, again, are very important clues and assessment categories. We're also estimating the presence or noting the presence of tenderness, which is pretty apparent when you palpate, and we're estimating depth. Is it dermal or subcutaneous? So the next consideration is about the shape and the arrangement or the configuration of the lesion. And these these are terms that not everyone's familiar with. Annular is in a circle, and I think of ringworm, Tinea corporis. Clustered, all grouped together. We see that a lot with different kinds of skin diseases, such as vesicles. We also see that in just multiple types of rashes. If it flows together or it's running into each other, it's confluent. We have some confluency in our case study today. Dermatomal, does it run along a dermatomal line? And I think most of us would think of herpes zoster, the shingles. Geographic, map-like, we'll see geographic tongue often in clinic. Reticulated, lace or net-like. There's a couple of viral rashes that have reticulation, and so that leads you to your diagnoses. You can review these. But shape and arrangement or configuration is very important. Again, within this consideration, an ability to describe and document and accurately diagnose. So here's just a few examples of shape and arrangement, okay? Often if you see an annular, a ring shaped with variation in appearance between the center and the periphery, so a lot of times the periphery will be raised in red and it'll be a cleared center, and that's a cue for Tinea corporis or ringworm. And I like the example of targetoid. A target-like with distinct zones, and it really looks like a bullseye. and often that can lead to the diagnosis of erythema multiforme. Just take a few moments to look at these shapes of lesions and the examples. I haven't seen a lot of nummular dermatitis or eczema, but when I did see it, it was exactly that, round like a coin. That's what nummular means. So it looked like dermatitis, but that round, discoid, coin-like shape is what led me to an accurate diagnosis. Just more examples of arrangement and distribution of lesions. Are they grouped, discrete, linear, dermatomal? Again, we talked about herpes zoster. Reticular. Are they photodistributed? In the places that the sunlight hits. So these are just, that's what I think is probably not common language for us nurses, but it becomes as we are more practiced and we get more accurate diagnosticians. And again, just a brief example of the dermatomal configuration of herpes zoster. I like to compare different skins of color because the presentation can look a little bit different. But you can definitely see those dermatomal lines and configuration of this disease. Now, I think that you could also tell me that this might be earlier disease. The lighter skin than the darker skin is later disease with some secondary lesion of crust. And I'd like you to think about it. What else do you see through there? Is there any excoriation or ulceration? So you can see that those terms are important in the description. And then finally, before we review and then do our case study, distribution. So you want to think about the extent of the distribution and the pattern of the distribution. So the extent, is it isolated, localized, regional, generalized, or all over? The pattern, is it symmetric? Is it unilateral, exposed areas, site of pressure, follicular, localization, random, or following dermatomes? Again, those lead us to diagnoses. So how do we describe and document these skin lesions? Exactly what we just reviewed. We consider and characterize the lesions by morphology, color, margin and size, palpation, what did we discover in consistency, the number, the arrangement and pattern, and the distribution. This is a case I had a couple days ago. So a 26-year-old female, 4 weeks postpartum, presents with a 6-day history of highly pruritic rash. She said it started on her lower abdomen where her stretch marks from pregnancy were. It spread to her lower back, her legs, her arms, and upper chest. She says the only unusual thing that happened is that she thought she was getting a fever blister last week, and she took 2 grams of Valtrex orally. She also takes a daily prenatal vitamin. She has no other symptoms. And I gave you on the speaker notes her medical history, which was essentially exactly what I just said. So the diagnosis is polymorphic eruption of pregnancy. And again, it wasn't important for you to know this diagnosis, but I want you to consider the type of lesion, the color, the margins, the shape, the size, the consistency, arrangement, distribution, and location. And you can see how I described it. Macular-papular, erythema, defined, margins, round or oval, warm to touch, multiple lesions, too numerous to count, symmetric, confluent in some places, and disseminated over those areas. So let's write it. Macular-papular, erythemic, non-blanching, defined, round, and oval, 2 to 12 millimeter lesions. The lesions are warm to touch, multiple, too numerous to count, symmetrical and confluent, disseminated on the upper chest, arms, legs, abdomen, and lower back. I hope this was the beginning of you recognizing and developing your skill in describing and understanding how those descriptors lead you to diagnosis of skin conditions. Thank you.